Hello, welcome to this webinar. My name's Robert Moots, and it's great to welcome you to this, whether you're watching this webinar live or pre-recorded. I'm a rheumatologist based in Liverpool, and I'd like to introduce you to the rest of the faculty for this 1 hour long webinar focusing on biologic treatment in Behçet's. First of all, we have Professor Fortune, who's the director of the London Centre of Excellence for Behçet's, and Farida is at Queen Mary, University of London. We're then going to have Graham Wallace, a scientist at the University of Birmingham and an expert on scientific aspects of Behçet's. We're then going to finish with Deva Situnayake, who's the director of the Behçet Centre in Birmingham. And a clinical rheumatologist who's going to be tying all these ends together and giving us a broad discussion of things. First of all, some housekeeping details. All of the attendees will be on mute for the meeting, but we really want you to be giving us questions. The questions will all be addressed at the end of the webinar, and you can submit your questions through the Q&A function on the screen. Please ask us questions. We will do our best to answer as many questions as we can. And if you've got any questions or technical difficulties about the webinar, then there is a chat box that's going to be helping you to get those addressed. So what are we going to be covering today? We're covering biologics in Behçet's. In a minute, we're going to start off with a background to Behçet's from Professor Fortune. I'll then develop things talking about the BioBehçet's trial, which is the main focus for this meeting. I'll cover the methodology and the clinical results. We'll then hand over to Graham Wallace, who's going to be reviewing with us the results of the exploratory studies on biomarkers. And then we'll end with Deva Situnayake, who's going to be discussing what the potential implications of this trial might be for future studies. We'll all have a general discussion afterwards where we'll try and answer your questions, and then we'll close after 1 hour. So now it's a pleasure to introduce Farida Fortune, who's going to give us a background about Behçet's. Farida.
Thank you very much, Rob. Thank you. I've been introduced, so I will simply start. I'm at the London Behçet Centre, and you can see Deva and Rob are at the other two centres in the UK. Should be able to. So Behçet, even its name is a conundrum. We all know this rare multi-system inflammatory disorder, which the pathology is mainly a vasculitis. There's problems around time to diagnosis, the diagnostic criteria, treatment, general and specific, and most of all, about the name. So Lucian Behçet described this in 1938. He published a treatise on urogenital ulcers and uveitis. However, he'd been working on this for some time and actually had a patient in the late 20s, 30s who had dental problems, who he noticed every time the dental problems were severe, he had oral and skin lesions. Hippocrates actually was before everyone and described this about 2,500 years ago. In his Apedium, in Treatise 6, he actually talks about in the summer patients, a group of patients getting the fluxus, aphthosis, and going blind. And then Benedictus Adiamantus is also Greek, and he was working around the same time as Behçet. And so now we have a problem. It's either Behçet, and some people call it Adiamantus Behçet. And so, next slide. Whoops, sorry. I need to go back. No, it's going forward. Let me go. Okay. Sorry, this is going forward. Yeah. So if you have a look, the clinical features are almost everywhere. And from going blind and getting hypopians to getting neurological problems, skin lesions, genital lesions, arthropathy, they all are part of this syndrome. However, the mouth presents about 90%, it's the most common, and then ocular and skin lesions are also common in this group. Okay. So where do we get Behçet's? And I said it's rare. But if you look across the world, you will see in areas where it is quite dense and you can have something over 100 and 30 per 100,000 to areas in Europe where we are, which is very, very much lower. And it mostly is 1.6, but really with the population slightly changing with migration, we have about 2%, and this is higher in Germany, where the percentage has also gone up. So the first conundrum, it's the time to diagnosis. And this diagnostic delay was a huge problem and the reason for setting up the centers. So you can see you can get recurrent oral ulceration, which is years before you get any other symptoms. But you can also get oral ulceration and very quickly get ocular or genital lesions and move along this within a few months. In COVID, we saw people move along this within weeks. So it is a conundrum, and you have to be aware of the clinical features to deal with this correctly. So there's different phenotypes, the genetics, the immune response, all of this, the environment, genetics, immune response, will contribute to which phenotype you have. The commonest is the mucosal. We have orogenital ulcers with arthropathy, then ocular, but all of those with ocular uveitis, and then neurological and then vascular problems are rarer. And also, you have to now include vascular changes. So the environment is very pertinent to all of us because of climate change, working and living conditions, and the things that we eat. The psychological effect of the change in the greater part of the exposome, it's called, has been huge, and it's been huge in the last 30 years and changing quite rapidly. And all of this changes our immune system, and most of all, there's a reduction in your health through dysbiosis. So if you have a look, so that's the external, the exposome, and then you look at the local environment, and you will see the mouth changes really quickly. And it's important to realize that there's several niches. So we only started realizing that there's a niche for viruses and changing microbiomes during COVID in the nose, but these are between the throat and the ear, at the back of the throat, in the mouth, and also where the teeth are. And the mouth forms this first barrier where it will prevent anything breaking the barrier by producing loads of IgA, which forms a Teflon coating preventive layer, and then all of these other molecules which will protect the barrier. So that's our environment. But the genetics are really important in Behçet's because I said that was a second thing that would change the phenotype. And if you look at the map on this side, it shows you where you get Behçet's and the highest proportion. But when you start looking here, you see that the changes in the genetic take place over a very long time. And you see sort of 1,000 years ago, how the Denisovians come out of Asia, go into Europe, go down into Australia, the humanoids come up, and the Neanderthals go into mixing with Denisovians and later mixing with humans. So why is this important? It's really important because you're mixing genes, and these genes are having effect on the expression of disease as you get migration. Really important. So these are landmark Behçet's patients. So Prof. Ono described this in the 1970s, but because it was in Japanese, nobody took any heed of it. And it was only in the 80s, and he was saying HLA-B51 is really important. Only around 2010, all the groups in the world, all of us got together and did the GWAS study, which shows that really it was HLA-B51. And then you've got some really quite fascinating work when Barnum looked at some paleontology samples and noticed that actually the Neanderthals had pushed the TNF gene into that population. And so that's one of the inflammatory genes. And then again, Dan Kastner and the group at the NIH started looking at the different genes and the association with this fascinating molecule called ERAP. And all of these, as you go down, you'll see change the genetic expression and the inflammatory markers in this population. Okay, so you can see that, hang on, let's just go back. Let me see if I can go back one. Okay, no, it's going forward. Okay, sorry, I'm going, yeah. Okay, so if you have a look at, so the phenotype expression, and this is where it's quite important, it's dependent environment, genetics, and the immune response. So our body's own immune response, which is both our innate and our adaptive immune system. And adaptive is quite important because has been a lot of work to show that infections are really important in this process of triggering a genetically predisposed person. Go forward. And this is the big conundrum in Behçet, is the diagnostic criteria. 1990, there was a group set up called the ISG criteria, but this really was for pathology when we were publishing papers, so there could be a commonality. And you would see you had to have more than 3 criteria, and so you'd have 1 major and 2 minor, or you could have 2 major and have noted for the disease. In 2014, Prof. Deva had been working on this for some time, since the 2000s actually, and he published a paper which had been validated, I think, in almost 30 countries. So it was accepted to say that you needed 4 points to have the diagnosis. Everyone forgot that he said greater than 4 points. And so the problem we have now is patients with oral and genital ulcers are diagnosed with Behçet's. And these actually are part of about 30 or 40 other clinical conditions. And so you get to a point where Behçet's is overdiagnosed, and that's a real problem. So you have to point out more than 4 points. I don't think, unless you're in Turkey and Prof. Gul's lab, you can do a pathology test properly. So I think in where we are, that shouldn't be used as part of the criteria unless you go back to the papers and see how to do this correctly. So on to my last slide. So when we set up the Behçet centers, we set up a treatment pathway from less complex disease to severe disease as you go up the slope and treatment strategies, and as you go down the slope with this less a severe disease, when it becomes intractable, you move from having simple anti-inflammatories to DMARDs and then to having a biologic drug. And you will see for almost all of them, the biologic drug, infliximab and interferon, was used and used quite widely. There was no trials in Behçet, so there no idea of which drug should be used. We were very good with all the other drugs with disease that wasn't severe, and this would then go on to the Behçet trial, which Prof. Moots will talk about. Thank you.
Thank you, Farida. I'm going to be talking about the methodology behind the Behçet trial, which is the main focus for our webinar, and also review briefly the key clinical results. So the Behçet trial was a collaborative endeavour between a lot of people, a variety of universities, and the UK NHS. It's been a bold thing to set up. The full title of it you can see there, and I'll explain why in a second. First of all, I have no disclosures for this, other than the fact I'd like to thank the UK Research Council, the NIHR, who've kindly funded both the trial and also this work we're doing now, disseminating the trial. I'd also like to thank Cesas, which is the company doing all the technical support for this particular webinar. As you've got the flavour from Professor Fortune, Behçet's is a challenge. It's a disease that people often find difficult to pronounce, let alone to understand. And when one's trying to develop a clinical trial, it's an even bigger challenge. Farida's hinted at some of the potential causes, the pathophysiology, but the truth is a lot of the treatment of Behçet's is eminence-based, and there's a low evidence to inform treatment. And one particular area where there's been a dearth of evidence has been how we approach the biologics. Now, Farida showed you the national pathway that we use in the UK for Behçet's, but those of you dialing in from other countries will be very familiar with the two drugs at the time that are the most widely used as biologics for Behçet's. First of all, on the left, interferon alpha 2A, rofiron, and on the right, infliximab. Both of them have got pros and cons. In the UK, we were very familiar with infliximab, but this is not a drug that's suitable for everybody. Rofiron would be more familiar in other countries, particularly Turkey, parts of Germany, where there's been a very high success rate reported, but people have been concerned about the potential for side effects. So what we set out to do was to do the first, and I think currently the only, head-to-head trial of two biologics in what in the UK is an extremely rare disease. So by doing this head-to-head trial with few patients in a single country, as you can imagine, there were a lot of headaches in designing the trial. Furthermore, we wanted to set up an exploratory arm that we'll hear about a little bit later from Graham Wallace about looking at potential biomarkers for either response to treatment or side effects. And the key thing we wanted to do was to develop an evidence base to help inform optimal prescribing of drugs. So how do we design the trial? Well, it's a pragmatic standard of care trial. It's a randomized two-arm parallel design, and we couldn't double mask it because there are very, very different ways of delivering the two drugs. But the assessor who measured clinical activity was masked to the actual drug being used. We recruited patients with a definite diagnosis, and we deliberately included patients with a variety of different clinical manifestations of Behçet's. They had to have refractory disease, and they were eligible for a first biologic drug according to the drugs pathway that we use in the UK. In order to design and power the study, we used a Bayesian design, and we calculated that we really ideally wanted 80 patients and that we would randomize them 1 to 1, so everybody had an active drug. And the clinical assessments were at baseline, 12, 24, and 36 weeks. And importantly, the primary endpoint was at 12 weeks of treatment, by which time we would expect to have a clinically observable difference. Very simple design. Patients, if they're eligible, would get randomized to one or the other drug. The first primary outcome would be at week 12. If they responded, they stayed on that drug until week 34 and then reverted to normal care. If they didn't respond or had unacceptable side effects of the first drug, they would swap to the other biologic drug. So we had the opportunity to observe exposure to more drugs than perhaps if we'd just done a very simple standard design. And that's important. The inclusion criteria were, as you heard from Farida, we used the 1990 International Study Group criteria, and you can see there how we defined refractory disease. There had to be no prior exposure to a biologic. We were looking at adults over 18, and of course, we had to be, they had to show us that they were able to give appropriate informed consent. The exclusion criteria, quite obviously, would be contraindication to either of the two drugs. If it was hard to comply with the treatment, for example, we take people in our centres from all over the country, and if there's a very long travel requirement, that may have precluded them. And we also excluded people who strongly preferred one drug compared to another. Graham is going to tell you in a few minutes about the biomarker analysis, so I won't cover that here. The predetermined trial outcomes, the key outcome was Behçet's Clinical Disease Activity Index at week 12, and the secondary outcomes were at week 24, and also individual organ system disease. What did we find? Well, briefly, you can see that at the end of the day, we screened 161 patients, and we had at the end 37 per arm available for analysis. The efficacy of both drugs was broadly similar. We were interested to see that. So both infliximab and rofiron were very effective for patients with Behçet's. What about other things? Switching treatments. Well, you can see that some patients switched treatment, and a slightly higher proportion of patients randomized to rofiron, that's the interferon, swapped to another drug. On the whole, that would have been through an unacceptable adverse event, although the numbers of those were low. The secondary outcomes really showed very little difference between the individual treatments, whether it was oral ulcer activity score, genital ulcer activity score, physician's global, which slightly was in favor of infliximab, but all of these others, there was no great difference between the drugs that we studied. And interestingly, when we looked at safety and tolerability, there was actually little difference in adverse events across the two different treatment arms. We'd not expected that. We'd expected a lot of side effects with alpha interferon, but that was not what we tended to find when we studied this in detail. So the conclusions from the clinical arm of the trial is that this is the first head-to-head high-quality RCT of two biologic therapies in Behçet's. We found both treatments comparable and effective, with a minor non-statistical superiority for infliximab. Both agents were allowed to give us steroid-sparing effects. And as we'll come to at the end, one of the elephants in the room is that rofiron is no longer manufactured, and we will be making a claim for there being a place for a rofiron biosimilar. These are all the people involved in the trial that played a big role, and we're very grateful to that. And what I'll do now is hand over to Graham to talk us through the exploratory biomarker results. Graham.
Thank you, Rob. For these types of grants, there's often very little money available for laboratory tests, but we were able to convince the NIHR that there are some analyses that we'd like to do. And one aspect with regards to rofiron is that there are some genetic polymorphisms that are linked with its efficacy. And it's normal standard care therapy for hepatitis C virus in a pegylated form. And what we find is there's a couple of polymorphisms that are labeled on the slide that will actually affect the efficacy in treating the patients with hepatitis C. So therefore, we wanted to look at these polymorphisms and see if any of our patients had these same mutations and whether that could actually be linked to changes or differences that we would see with Rofiran treatment in particular, as opposed to infliximab. So let's move on. There we go. So what we were also doing was a metabolomic study. So we took urine samples from these patients that were collected at the time points of the trial, so 0, 12, 24, and 36 weeks. And we analysed them for metabolites using NMR spectroscopy. And metabolites showing the greatest discrimination between the groups were identified using multivariant analysis and the human metabolome database. These next slides are going to have the same format. What we have here is the principal component analysis, and these are certain of the metabolites that you can see a difference between them. And these are the statistical analysis that we've done on the basis of this. So this first slide is taken at time point 0, the patients that went on infliximab and the patients that went on Rofiran. And what's important to show is that there was very little difference between these patients using the principal component analysis. So, and as Rob said, we randomized the patients into the trial, but this data suggests that our randomization was effective, and we were not sort of separating out two different groups of patients with Behçet's disease that could in fact influence the various treatment responses that we have. And while there were certain metabolites that we could measure, would be different between the groups, when we do the analysis for all of the metabolites measured, we find that there is no significance of any of those ones in particular. So for this point of it, the fact that the patients had the same metabolic profile as we started the trial was actually very positive in our view. This is looking at Rofiran versus the 24 weeks sample. And again, while there are some differences between particular metabolites, when the analysis of the group is concerned, we don't see any major differences as far as that's concerned. So there doesn't seem to be any major alterations in the metabolite profile, the urine metabolite profile, when we are treating patients with Rofiran for the 24-hour time point. Right, if we can just go back. Yeah. So this is infliximab at the same aspect. So we've taken the time 0 versus time 24. And again, what we see is there's been no major changes, although there's some particular metabolites that we may consider showing a difference. But when we do the overall analysis at the statistical level, again, there is no major difference between the metabolite profile at time 0 and time 24 in the urine samples from these individuals. However, when we look at one aspect of it, we were taking infliximab at time 24, so 24 weeks in, And we looked at what would be classified as responders versus non-responders to infliximab. Again, the profile at the PCA looks clean, but we do find one of the metabolites remain significant after we've done the analysis, the statistical analysis of all the metabolites joined together. And we can look at this further in a database from the metabolites to see what pathway that might be involved in and what that might be telling us. So we did not see any changes that remain significant for interferon, but we have seen them with regards to infliximab, at least one metabolite that may be different and something that could be followed up. So in conclusions to the lab-based side of it, with a larger sample size, the association that we've seen in the genetic polymorphisms may actually be real, and we could actually develop this further in interferon treatment. Again, as Rob said, interferon is no longer available, so we wouldn't really be able to do this study to any real benefit. We didn't see any significant metabolomic difference between the cohorts at D0, so we're happy that the randomization worked effectively, and we weren't putting the drugs into individuals with a very different metabolomic profile. And there may be one at least potential metabolomic difference that we could identify in the infliximab arm that could give us some indication as to how this aspect is working and how infliximab is working. And that's something that we may take forward in the future. So thank you very much. I'll pass on to Deva.
Thank you, Graham. So thanks to the team. It's up to me now to answer the so what question. So in summary, in this presentation, I'll move on to the next slide. It seems that the slides are moving very slowly. So in this presentation, we've described the first head-to-head RCT comparing the two main biologics on our national treatment pathway used to treat all subtypes of refractory Behçet's. We use these two agents at the usual point in our pathway where biologics are considered for resistant or acute or active severe disease. Both agents were equivalently tolerated and effective, with perhaps a minor superiority for infliximab. Both treatments had important and useful steroid-sparing effects, with steroids withdrawn in 20% of cases on steroids in patients with infliximab and 44% of cases on steroids with interferon alpha. We didn't encounter any major concerns with depression with interferon, using our pre-screening protocol for depression in contrast to the literature, so that was reassuring. And we also, as you've heard from Graham just shortly, that we identified some promising genomic and metabolomic signals for response, as we've heard, which are worthy of further study. Next slide. So what comes next? Oops, that's the wrong slide. Yeah. So what comes next, and what are the implications of our findings? First, we have to accept that a trial of 24 weeks duration is probably not long enough in a condition such as Behçet's, characteristically prone to relapses and remissions over prolonged periods. A period of longer-term follow-up for each group after the trial would have been ideal, but unfortunately wasn't possible because of the interferon wasn't available. However, we do have multiple uncontrolled observational studies in various populations that indicate that for both agents, sustained effects are achieved over prolonged periods. So some of these studies indicate a tendency for earlier relapse after treatment cessation with anti-TNF therapy compared to interferon alpha. This might suggest then that perhaps interferon has unique properties to induce a deeper, more durable remission. We also know that secondary failure may occur with both agents, though as far as we know, the hacker phenomenon appears to be a phenomenon seen with anti-TNF therapy. Next slide coming. So here we see the relapse-free remission data for interferon from one of Christoph Deuter's early German studies. This is reporting on interferon after one course of usually an 18-month period for ocular disease, and where you can see on the right that a near 95% response rate was observed. And if we look on the panel of slides on the left, the graphs, you'll see that there was relapse-free remission of 75% after 19 months, 50% at 46 months, and 25% at 107 months after ceasing therapy. Though, as you can see, at the longer periods of follow-up, the numbers were quite small. However, several other studies have reported similar findings and response rates for ocular disease. So for infliximab, once again for a refractory uveitis, here we see a similar magnitude of overall response of 89% for one of the studies summarized here, and perhaps with a slightly higher risk of early relapse when used as part of a step-up regime in combination with corticosteroids and another immunomodulator. Again, there were important steroid-sparing effects observed. Multiple study results were also pooled in a systematic review informing the EULAR guidelines, which also concluded that complete response rates were similar for both agents. Sustained remissions were also slightly higher with interferon, and corticosteroid cessation slightly higher for interferon. So we're all familiar with the downsides, particularly of anti-TNF therapies, which are well recognized due to the work that's been done with the biologics, BSR biologics register, with an increased risk of sometimes serious infection, including the risk of TB reactivation. So this might be particularly relevant in high-risk groups and populations across the world. So here we see a summary of the characteristics of the two agents. Both are recommended in EULAR guidelines and now in the recently published Living BSR BAD guidelines. Both agents work quickly, but as with RA, an anti-TNF is generally used in combination with an immunomodulator such as methotrexate or azathioprine, whereas in contrast, interferon alpha is generally used alone, and when given in combination with steroids, these are usually quickly tapered, fairly quickly to below 10 milligrams daily within a month or so. Co-therapy with azathioprine is avoided with interferon because of an increased risk of myelotoxicity particularly. You'll also note that for both agents, the duration of therapy remains an empirical decision, not based on evidence. So our trial demonstrated equivalence, but in practical terms, there may be factors that favor either one agent or another, and these are summarized here. The risk of depression in up to 30% of some studies in interferon was not seen in ours, but interferon would be avoided where there is a risk of important mood disturbance with a history of depression. Interferon might perhaps be a better choice in regions or settings where TB risk is high and where the preference would be to avoid co-therapy with another immunomodulator or significant steroid doses. The prospect of at least initial daily subcutaneous injections might also be a factor in patient choice for some, but both forms of treatment may give rise to important hematological side effects, including cytopenias, and both agents require monitoring. Rarely, interferon may also induce autoimmune disease. So for interferon alpha, there remains a particular unanswered question on the precise mode of action. And as we can see here on this slide, interferon alpha has a range of relevant properties, and in the non-pegylated form has a quite short half-life. The precise dose-response relationships have also not been fully worked out. Interferon has a pleiotropic mode of action, and after binding to its type 1 interferon receptor, it activates two JAK molecules which permit binding and activation and phosphorylation of STATs. And then this leads on to subsequent intracellular signaling pathways, resulting in a type 1 interferon response and activation of a large set of interferon response genes, priming the immune system for antiviral defense, including upregulating MHC class 1 expression. There are a variety of effects shown in the lower panel, both affecting the adaptive and the innate immune responses, together with increasing Tregs and modulating IL-10 production, all of which may be relevant either alone or in combination to explain its efficacy. So what we don't know is which particular target cell populations are more important and responsible for interferon's efficacy in Behçet's, and this would of course be worthy of further study. So there remain some other important unanswered questions in relation to the biologic therapy of Behçet's, which should also be addressed with proper stratified clinical trials in the future. First of all, for both anti-TNF and interferon, once durable remission has been achieved, how long should we continue with therapy? And what are the risks and predictors of relapse when we stop the treatment with either agent? There's clearly an unmet need here to identify predictive biomarkers for potential flare and deep remission, as well as identifying personalized signatures for treatment response. Tissue biopsy-based studies using the cancer model with new technologies such as single-cell RNA sequencing and spatial transcriptomics may have potential for exploring this further in the context of a bioflare type study, as they did in RA, where we stop the treatments and study the patients prospectively. Further work could also be planned in responder and non-responder cohorts to examine our preliminary signals for metabolomic and genomic markers. Another key question remains how early we should be using biologics in the treatment process. Probably much earlier, as the Leeds RA team led by Paul Emery has recently pointed out for RA. Intuitively, much earlier treatment does appear to induce more durable long-term remissions, and this is work coming from Petros Sivakakis in Greece, who was one of the early users of infliximab in Behçet's. So intensive early drug use might also be capable of inducing a more prolonged, durable remission. Another important point is where in the pathway should we use these therapies, and we must remind ourselves of the work that's been done in Crohn's disease, another common autoinflammatory disease, where a recent study published in The Lancet in 2024 showed that much earlier use of anti-TNF therapy led to sustained steroid-free and surgery-free remissions in up to a large proportion of patients compared to the traditional step-up regime that we use. So the elephant in the room is, of course, the sad demise of interferon alpha. It's no longer available either as interferon alpha or now even in its pegylated form. We believe that there's a strong case for pharma to develop a biosimilar or to further explore pegylated interferon alpha or alternative mechanisms of delivery or targeting interferon alpha receptors using either coupled engineered binding proteins or Affimers, or extending the half-life of the agent in some other way. So our offers go out to pharma to collaborate on this. You would be welcome. Several studies have also indicated that up to 7% of anti-TNF therapy treated patients will relapse on treatment each year, particularly those with more serious disease with vascular involvement. So we do not need to lose an important effective treatment. We've also heard from Graham that there's excitement to further explore the potential for biomarkers for precision medicine, and perhaps the use of new texts such as tissue-based studies linked to transcriptomics and machine learning. One thing for sure is clear, that the combined centres of excellence have demonstrated the capability to address some of these important challenges that should occupy our minds for a few years to come. So I'm looking forward to that, and I'll hand over to Rob.
Thank you, Deva, and thank you all for listening. We got a few questions coming in. We're going to be running through some of these. we've got some general questions and we've got some trial-specific questions. So I'm going to start with a trial-specific question. I'm going to ask Professor Fortune if she could please answer the first question, which is, in the Behçet's trial, the primary outcome was a composite score, which would have been contributed to from various different parts of the patient's disease activity, whereas other trials have focused on an individual organ score, such as mouth ulcers. Professor Fortune, would you like to comment on the pros and cons of these, and perhaps why the composite score was the one that was gone for in the Behçet's trial?
Yes, I think if you go for single organ, you're missing a huge amount of data. You're also missing quite a lot of the side effects and the pathogenesis of the disease. And I think for these sort of trials, and because Behçet's is not particular organ based, as multi-system, and as you know, the vasculitis is really widespread. You have to have a composite to make any sense of whether your drug's working or not.
Okay, thank you. And also, we wanted to use a pragmatic kind of outcome, what we're using from day to day in the studies. Here's a question from Ali Alcazaz asking, why did we choose infliximab and why not Humira? Perhaps I could direct that to Dr. Situnayake.
Yes, thanks, Rob. Well, yeah, that's an important question. I mean, at the time in our pathway, infliximab was the main biologic that we were using. So from a practical point of view, we wanted to test out that agent. We are aware now, of course, that as time has gone by, that increasingly adalimumab is also being used either first off the bat or after a switch from infliximab for patients with Behçet's, and that there's some recent evidence that has now been published that shows perhaps that in the medium term, adalimumab is more efficacious. So really, that was the basis for that decision.
Okay, thank you. We've got Madi Vorjanian, who has asked a couple of questions, and that's really what's our sense about the role of apremilast, cyclophosphamide, and mycophenolate, and indeed JAK inhibitors. So perhaps I'll address that. Certainly around the time of the trial, this was quite a few years ago. So though we'd used cyclophosphamide, we kind of felt that the biologics provided a more efficacious treatment with a reduced side effect profile. So that's why we chose the two biologics that we did. Rather than cyclophosphamide, and there is a place for cyclophosphamide in Behçet's, similar for mycophenolate mofetil and related drugs. Again, we want to go for a simple head-to-head of two agents, and that's why we really went for those. But there can be a place for these other drugs, and I think the jury's still out a little bit on JAK inhibitors. I would be keen to see a good evidence base accumulating to really understand a little bit more about that. We've got a couple of questions from I think patients, and I'm just going to perhaps ask the first one to Professor Fortune. This person who's anonymous is talking about wanting advice on starting a biologic earlier in patients under 18 years old, and who's been looking at early use of biologics, particularly within Greece, because I'm assuming this patient is dialing in from Greece and therefore would be of interest either to them or maybe a family member.
Okay, so in the UK, we have been using the biologics as part of our treatment protocol. So usually in patients who are refractory or severe disease, whether they were children or adults. I know because I also work in Crohn's that there's been a lot of work in children with Crohn's and starting a biologic as a first line, right? And I think some people would have seen the trials with children. that if you start it really early and antigen exclude, they tend to go into remission for much longer periods.
Okay, thank you for that. And a question from a Jacqueline Pooler, I'm going to put to Dr. Situnayake. David, were there significant differences in patients' responses in the trial based on their age, gender, and the duration of the diagnosis of Behçet's?
Not really, because we used a particular methodology in our trial, which Rob referred to, which was a Bayesian design. And that was done because Behçet's in the UK is a rare disease, and we were looking at an even smaller subgroup of patients who required biologics. And that meant that the numbers of patients in each of the two groups were quite small, and it wouldn't really permit any relevant analysis of smaller subgroups within that. So the study wasn't really powered to be able to detect differences between. In practical terms, we do know that patients with Behçet's do differ in terms of their outcome comparing men to women. And in general, it is said, particularly for younger men, that they have a much higher risk of ocular disease and poorer outcomes. But we weren't able to address that particular question in this study.
Thank you, Deva. So, Graham, you've had a quiet time for a little while.
Yes.
We've got a question for you, and that it's very tantalizing the fact that the metabolomic study suggested that there is some signal there, which might be useful in predicting response to a TNF blocker, at least to infliximab. How could that be worked up further? And what are your expectations? Is this going to be a promising biomarker, or is it just not going to be practical?
No, I think it's got the potential to be practical, and as you say, to use this in understanding who might benefit best from going on to infliximab. What we can do, the way that metabolomics are analysed, they're put into what are known as bins, and within each bin there is a number of metabolites there. We can then identify the individual bin, and then we can start to look for the metabolites that are present there and identify those ones which we see are different. As you say, the benefit from this, and it comes back to some of the questions about should we give biologics earlier in the disease to give a bigger beneficial hit? And if we were able to do that in individuals that we know are going to respond better by identifying these metabolites, then that would be a possibility. Now, of course, we need to, even identifying it, we need to work it up in such a way to see whether this is a longitudinal response. We see that this molecule is always there and is always changed. But the potential is there for doing that type of study.
And just a supplementary one, somebody's just asked for you, Graham, will there be research into a particular gene or genome which may influence the activation or presence of Behçet's?
Well, as Farida mentioned in her introduction, there have been quite a lot of genetic studies. The GWAS study from 2010 led the way on that, but we've now probably got about 40 or 45 different mutations that we could say are associated with it. Very few of them are associated with particular manifestations of the disease. And it's still not absolutely clear why any combination of those mutations could actually lead to the disease that we see as Behçet's. Some of them are related to, for instance, TNF, an increased production of TNF, which could obviously be involved in the vasculitis that we see. Some of them are involved, for instance, in IL-10, which is more anti-inflammatory. So we can argue, we can see where there's pathways involved in this. But like many of the genetic studies, we're not really at that stage even now, where we could say we could do the genome screen of an individual, and then that would tell us what manifestations of Behçet's that we're going to get, with what severity and what treatment would be best for them. And that's really where we want to be going forward.
Thank you, Graham. And Mardi has sent us a number of questions. So I'm going to try and tie his questions together because they're very good ones. Madi's working and living in Iran. He's shared his experience of good responses in people with CNS Behçets to cyclophosphamide, and that's good to hear. And we're also aware of that. We would tend to go for a TNF blocker in preference to that now, but there is a role for cyclophosphamide, and I'm glad that's been effective in your patients. But you also wanted to know perhaps what do we do for patients with Behçets who don't respond or a TNF blocker is contraindicated. Well, we know we can't access Rofiron. One of the things that we want to do is lobby for biosimilar Rofiron to be made available around the world for Behçets. There are companies that make biosimilar Rofiron. There's a big potential market because Behçets is a prevalent disease amongst various areas, and we're very keen to try and lobby to get that available. Mardi mentioned about what about tocilizumab? Well, that's a drug that we believe has got good promise for Behçets in a variety of manifestations, particularly perhaps vascular manifestations, ocular manifestations, and we're keen to actually get some clinical trial evidence rather than anecdotal evidence. And we're also aware of the IL-17 inhibitor secukinumab having a potential role in non-ocular Behçets. And in fact, Deva, Farida and I are just finishing a big trial looking at secukinumab in non-ocular Behçets, and watch this space for the results that are going to be coming out later on in this year. So very good questions there. I don't think we're going to have time to be able to answer any further questions, and I'm very grateful for all the questions that have come in. Just to wind things up, I'd like to particularly thank you for dialing in, for asking your questions and sharing into this trial. We've got some details of the publications from the trial, which you can look up. First of all, the BioBehçet's clinical arm has been published, and you can find that in Rheumatology. It's also published by the Research Council NIHR, and we can give you links to access that. The exploratory biomarker study is accepted for publication and is in press for an excellent journal, Rheumatology and Immunology Research, and it's going to be coming out in the next issue, and it will be available online for you to access. I'd like to thank our faculty. I think they've been great presentations, a very good background, good scientific understanding, and a great discussion. And I'd like to again thank the NIHR for funding this, and a special thanks to Cesas, who's been providing very good technological backup. They've run the webinar, and they've been really, really instrumental in the success for this. And finally, we're really keen to hear from you. As well as our thanks for your attendance, and we hope that you've enjoyed it, we'd like to ask you to fill in a short evaluation form, which helps us to know your thoughts about things. And I'd finally apologise for those of you that have asked a really good question, but sadly, time has not allowed us to answer them. You might want to contact us independently. We're very keen to discuss all of this further with you, and we'd like to thank you again for your participation in this. Thanks very much.